Yeah. Okay. Thanks, Debs. That is absolutely brilliant. Hi, everybody, and thank you so much for inviting me. Sorry for the mic. My name's Rachel. I'm the Chief Executive of the Patient Association, and we're in a non-disease and non-condition specific charity. I'm very delighted to have Fiona as one of our trustees. So, Debs, before I go on to telling you about the two reports that we did, so for us at the Patient Association, we really believe through a lot of work, through strategy development, when I probably drove Fiona quite insane of COVID had started, and I said, we need to do a strategy, even though we're online, we need to do our strategy. And we did it over a painful few afternoons on Zoom as we tried to work out actually what is it that will make healthcare better for patients. And we really genuinely believed the patient partnership in the design and delivery of services was the way it had to be. And believed that happened, it was A, better outcomes for patients, B, probably more motivational for staff, and actually going to be a lot safer. And we tested all the scenarios. So then I was left to look at what did our theory of change say? Actually, how did we get to that patient partnership? And what we really decided as a trustee board and staff was that you had to have shared decision making. Shared decision making was the way forward. But our theory of change looked at two different places. And it looked at healthcare professionals. And it said, well, actually, what do healthcare professionals need to do? What do they need to know? And actually, you summed it up. You need to give the power to the patient, and you need to allow that patient to have that power. And a lot of that's about confidence, because when somebody comes into a healthcare professional arena, into a patient comes in, and maybe you don't have the knowledge, but you have to say, actually, I think we need to talk to someone else. You have to start with what matters to you. What's your life? We're all here to live our best lives, which your survey earlier on, some people said 2 years, some people say 10 years. But then the other part about that is the patient, and the patient feeling that they have the power. And one of the things I spoke yesterday about was there's a wider issue outside health and care. And the wider issue is our well-being of our nation. And in the first 5 years of your life, and what happens in the first few years dictates that power. So when we interact with healthcare, we need to know that our healthcare professionals are going to help us have that power. And I was challenged by a patient for using Empower a few weeks ago. And they said, but if you empower me, that gives me an impression that you can take that away again. So actually, you've got to give me the power. So how are you? That's good to see you. So I'm here to talk to you about two reports that we did. So again, when we started our strategy, I said, well, we actually have to understand what patients and healthcare professionals feel about shared decision making. What does it look like? What are the barriers? So I only have a few minutes because you've got a lot to talk about today, but I hope some of this will help. So we did two reports. We did one in 2021, and then that raised some barriers, and we were lucky enough to get some funding to go into 2022 and to actually go to healthcare professionals. And that was a bit of a risk, the Patient Association going to healthcare professionals, because I didn't know they'd completed. So I was very excited when I reported back that we had over 1,400 responses. And the title for the first report was, is it a shared reality? Is this what people are experiencing? And it's not. It's not what the patient or public are really experiencing out there. Or is it just that insider jargon? So first of all, thank you for using our jargon busting dictionary. But we pulled together what we thought shared decision making was, and this is before our jargon busting dictionary. And I'm not going to read these out, but there are benefits for patients. There are better outcomes. We're answering the question of what matters to you, what's important, how are you going to live your best life, what's important to you around your family, your core. And I come from working in children's hospice care, and so the one thing we had to accept there was children weren't going to live long. But actually, we could make sure they had the best life they possibly had, because we started with what matters to you and your family, and how can we create those memories for your family for the future. So what we found. So again, I'm not going to, but I think you'll probably, Debs, experience some of these. You'll understand these. There was no follow-up, no discussion. My doctor didn't give me any opportunity to ask questions, telephone consultation, I was sent for diagnosis, no opportunity to ask questions. We hear this regularly through our helpline. So we run a national free phone helpline that's about advice and signposting. And we regularly have people coming to us saying, my son was on this treatment. They've just took him off this treatment. We don't know where to go. How do we get this? How do we get second information? So, we're regularly being asked these questions. So we ask them what support you'd like, and, being listened to, what would make you, and communication. So one of the things I do is I sit on the elective task force with NHS England about people waiting for surgery on the elective, well, they're on the elective surgery. And we know how long those waits are. And actually what patients tell me is, I know I might be on that list for quite a long time, but what I need from you is information. I need to know that you're going to contact me in 3 months' time. I need to know you're going to contact me in 6 months' time. I get that it might be delayed again. I get where we're at, but I just need to know. So we've had to work with them to really put together really good communication principles. But then unfortunately within NHS England, I have to tell NHS staff where to find those communication principles on their website. So we're still not working with patients, even though they say they're listening to me and they're developing this, but patients are not getting the communication. They're not being listened to. And I think there's a long road before we really realise the patient partnership and shared decision making across health and care is the way to do it. But so it means I have a job for a while yet. But getting Debs and Hamid and having patient voices, we have a lived experience advisory panel. And I recruited them all on the basis of the fact that they were experiencing inequalities. They had different issues going on. And, I watched one individual with very severe mental health needs. All services have been closed to her because she's angry. Because she's angry because she's not getting the service she needs. She's angry because she's got really bad mental health condition going on. And yet, everywhere she turns, people discharge her from the service because, they think she's angry. But why? They've met her angry. The health system has met her actually really angry, and it's actually met her sicker. And we regularly meet those. We have another gentleman who went for treatment for prostate, and he's really bad learning disabilities. And this consultant met him. He rang me. He showed me the letter. I didn't understand the letter he got. And yesterday when I was speaking with the private sector and the independent sector, and I was saying, if you are going to want to do shared decision making, think about your communication. Think about your written communication. Health literacy out there is 9 years of age. And how do we write to people? Because it was that consultant's letter, and I'm sorry, but it was pure lazy. He was writing a letter that he could CC a GP into, and he did not care for 1 second that this gentleman, very stressed about prostate issues, would not understand it. But he had ticked the box. He had written to the patient. Not good enough. Okay. So what patients want, I've said it there, but these are some of the stuff that came from patients. I want to be listened to be treated as an equal. I know my body. I know what I need. I need my trained, and I get that healthcare professionals are very well trained. I need you to come to me with your knowledge and say, actually, Debs, like you said, don't push people off elective lists because you've got an excuse. I have another story from somebody we're doing focus groups with patients about what do the principles of patient partnership look like to a patient. And one patient told me the story, and how do we feed back into the system, and how does the system listen to what we feed back into? And one patient told me a story that he was chronically obese and he needed treatment, but he couldn't get the treatment because he was chronically obese. And he was told by his consultant and his doctor that he needed to go on a diet. And just like you, he would leave his GPs and he'd go straight to McDonald's and he'd have a cheeseburger, because he said he didn't know how to deal with it. Nobody was giving. There was no holistic. There was no, social prescribing and other non-accessible language. There was nobody around him and wrapping him and saying, actually, how do we support you with this? And then he said he'd get a text saying, how was your GP appointment? And he was like, well, it was great. 9 out of 10, they were lovely, but I'm sitting here eating a burger. So it's had no difference on my ability to live my life. And I think we have to think about, if we're going to do shared decision making, how we look at patient experience, because the way we measure experience in the system is the impact of the treatment, how the system has worked, rather than taking patient experience and saying, actually, so you saw your GP today, or you went to see somebody today. Actually, how's that let you live your life to the full? How has it answered that what matters to me question? And I think that's what we need to, I'm hoping we can get some funding to do that next year. So I'm not going to read any more of them to you. So then we went to the healthcare professionals, because actually what came out a lot in our patient survey was that when we had some healthcare professionals take part in this patient survey, and they said that, the training wasn't really there. It's a soft skill, isn't it? Communication. If it's not taught, if it's not tested, it's not learned. And that's what a medical school told me before. And quite often, your kind of module around communication and listening, they're not taken seriously. And we have to make shared decision making and listening and learning and hearing and actioning really quite part of that. So after that report, I spent a lot of time talking to different people, and I thought, hold on a second, is it related to training in university, in your medical schools, wherever you are, or is it culture? Is it when you go into an organization, if it's a really open culture that values shared decision making, will it work? It's both. The survey pretty much proves that culture is really important, obviously, in an open and transparent and a culture where we're able to have that conversation. But for those professionals, nurses in particular, where shared decision making is really part of the curriculum and really taken quite seriously, they see the benefits much more, and they work with it much more. So what they strongly really, but actually it was good. It was really strongly positive, the shared decision making overall. And like I said about nurses, training has improved, and we did do a study back to the age profile of our surveys and the training that happened. So one of the theories that we have, but we need to test it more, is in time it seems that shared decision making is happening much more through the medical curriculum. So in time it probably will come out, but there is a real important thing that you have to come into a culture where it's welcome and expected. But then there was 3 barriers, and 3 kind of key barriers. 2 I'm not so sure about, but the healthcare professionals identified them. The third was, one is about IT systems. And a lot of what we heard, and anyone working in the NHS might see this, is that you get the circle of doom. To find out anything about a patient, you have to be able to access 3 or 4 different systems. You've got to look. I've seen somebody over there. Sorry, I don't know your name. You're never going to be able to do if we're working, and the other 2 were resource and time. And we know that we have an underfunded workforce. We know that we need a proper workforce strategy. All of these things, if you're working in the way that we hear people within hospitals are working, and the healthcare professionals have had a torrid 2 years. Patients have had an extremely torrid 2 years. But if you're working in that way, does good practice just slip out the window? Or are you just going to go, there is a list of things, but actually if I just tell them one, they'll agree to that and they'll get out quicker. But nurses really saw that if you spent more time, in the first, specialist nurses in particular, and hospital doctors, if you spent more time in the first appointment with somebody and got to know someone really well, that actually it saved time in the future. And that's probably what we have to try and work with healthcare professionals. And one of the things we're working on at the moment is the fuller review of GP workforce. And looking at actually people with long-term conditions, how they have that continuity of care. And then someone else like me, who's lucky enough to only see my GP once in a blue moon right now, touch wood, doesn't really care who they see. I just need an appointment to get something dealt with. So we are going to have to think about how we do that continuity care, so that shared decision making for long-term conditions in particular can be the first. So what we What we are doing, and I think I think yesterday I might have mentioned partnership about 200 times during a whole day and actually apologized in the end for saying, but it's patient partnership. So, you know, we do need, and I said earlier on, we need to look at the patient experience. What difference, Debs, that first consultant you said, a huge negative impact on your ability to live your life. Your second consultant, if they came and measured both of those experiences, yeah, no, I can see you there. 2 minutes actually, because I'm nearly finished. And then the next is that there are a lot of tools out there, and I saw that you did the brand tool there a minute ago, the benefits, the risks, the alternatives that do nothing. There's a lot of tools out there, and we're working with the National Programme Board for Shared Decision Making. And actually, we're having a patient partnership week at the end of this month. So you might send out the details, because we're actually bringing examples of how shared decision makings really work quite well in there, with a big project that you're involved in Nottingham, isn't it? Yeah. But there are gaps. And I think for me, the gaps there as well are around inequalities of health. Because, if you look at some of the shared decision making that's happened about how you access appointments, be it whether, when are we starting shared decision making with looking at the very beginning before you even access the service to work out about how you're going to access that service. So, we had heard this whole thing about brilliant digital online. I'm sorry, all our patients got telephone calls. There wasn't a huge amount of digital online. What if English is your second language? What if you have learning disabilities? What if you don't have a safe place? And, as we look at cost of living and the crisis that's coming, what if you don't have Wi-Fi? What if you can't afford Wi-Fi? So we have an awful lot more, and we have to think of that power balance, and poverty creates illness. We all know that. So what we're going to see as we watch this cost of living crisis, as we know as this happens, that patients and the public are going to lose more power. So as healthcare professionals, you have to work to give that power to the patient. And then I've talked about the clinicians and the training. There, I'm 20 seconds ahead of time.